have about physician's average annual income is from 2018. So let's distinguish between the two main areas of practice, which is the general practice or primary care and the other one with subspecialty care. So primary care physicians, for the most part, earn about $223,000 annually, and subspecialists earn more than $100,000 more than generalists at $329,000 annually. And perhaps because of the difference in wages, there are less primary care physicians in the overall physician population. So in the US, there are about 80 primary medical doctors per 100,000 population. If we further break that down, it's worse in the rural areas. There's only about 68 PMDs per 100,000 population. Now, what we also need to remember here is that rural areas are not densely populated like urban areas. So in terms of distance, this 100,000 will be spread out in a bigger area. That means in terms of traveling to get to a physician, it's actually worse in rural areas. And in urban areas in the US, though, it's about 84 per 100,000 population. Now remember, primary care is now supplemented by other healthcare professionals. We have nurse practitioners and physician assistants that do primary care as well. Currently in the United States, we are experiencing a practice maldistribution for physicians. And there are two types, geographic maldistribution and specialty maldistribution. So in terms of geographic, more physicians actually work in urban areas, metropolitan and suburban areas, rather than rural or even inner city areas. So there is a sort of comparison here where they put rural practice and inner city practice side by side. This means that even though in inner city areas and they are in metropolitan areas, there are specific pockets within that city where there will be a lack of physicians in terms of per population density. And the reason is better living standards. There's more chances for professional growth, as well as professional interaction with colleagues. In metropolitan areas, you also find the modern hospitals there, so you have the facilities and the technology. In terms of specialty maldistribution, we're talking about the imbalance between those who practice general medicine versus those who practice subspecialties. So in the United States, the ratio is this. 38% of all physicians are general practitioners, and 62% are subspecialty practitioners. Versus if you look at other industrialized countries, it's almost the same. It's 50-50. The challenge of the specialty maldistribution is exacerbated by the fact that there is no national policy or a master plan on how to achieve some balance between the ratio of generalists and subspecialists. And historically, there's been a back and forth, undersupply, oversupply of primary care physicians. And there's really very little overall change. And despite what the government is trying to do, there's really not much changes that have happened. Now, because we don't have a centralized agency from the government to regulate our healthcare delivery system, because we don't have a universal healthcare, the government can only do so much, and this is more like encouraging physicians to practice primary care by enticing them with loan forgiveness, cash awards like grants to pay for medical school. But In the United States, the career choices of physicians really depend very much on their own decision, and apparently earning capacity is a big reason for it. In terms of specialties, especially between general practitioners and subspecialists, the choices are influenced by the hierarchy of prestige, the level of respect among colleagues, also the perception of the public. People think that subspecialists are smarter, or they have more training, or they're more knowledgeable. In some respects, it's true because of the longer training they have, but it doesn't necessarily mean that they are better off than general practitioners in terms of patient care. It also seems that teaching hospitals, the culture favors specialists. And of course, I mentioned about the earning potential. There's also the market conditions of supply and demand. Although in terms of this, we know that we need more primary care providers, but it doesn't seem to work towards that solution. Medical schools, however, have started to encourage primary care practice, and they are trying to expand programs for general practice and more emphasis on ambulatory training. In terms of physician education, there are 2 academic degrees awarded in the United States, and they are both equivalent. They are equivalent to each other. And these are MDs, Doctor of Medicine, and the other one is DO, Osteopathic Medicine, Doctor of Osteopathic Medicine. Both MDs and DOs use traditionally accepted Western medicine techniques, including the use of medication, surgery, but there is a big difference in terms of training. In terms of practice, there's really not much, but in terms of training, this is where you see a bit of a difference in the philosophical approach in terms of patient treatment. So MDs use what we call allopathic approach. It means that they're concentrated in looking for a disease, symptoms, and then to intervene and treat whatever is causing that symptoms and therefore the disease itself. That's why it's medicine, because medical treatment, and medical treatment is the intervention. And the goal is to produce a counteracting reaction to neutralize the effect of the disease, such as the use of medications, a chemical agent, for instance. That is medication. DOs, or Doctors of Osteopathic Medicine, on the other hand, tend to concentrate on preventive treatments, and they use a holistic approach, the whole body approach. They do not only focus on what's wrong, the symptoms or the disease, but they also look at the entire person. And because of that, most DOs are general practitioners. Most of them are generalists. DOs also have this specific type of training, which they alone are actually trained for, and which allopaths or MDs do not have any training for, and it's called Osteopathic Manipulative Medicine, or OMM. And OMM is a therapeutic application of manual pressure for structure and function in bones, joints, tissues, muscles. They can be used to treat headaches, arthritis, stress injuries, sports injuries, back pain, neck pain, shoulder pain, and it's non-invasive. And because DOs are also trained in Western medicine, they can combine this with other medical treatments, medications, pain relievers, and things like that. So in the United States, the way the latest data we have is from 2014. In terms of academic preparation, a huge majority are trained as MDs, 92% in terms of physicians, of course, and 8% are doctors of osteopathic medicine. Let's discuss the area of practice for physicians and the two general types of practice, which is general medicine and subspecialty medicine. Before I proceed, though, notice that I have sort of really shied away from using the term specialist, and I have been using subspecialists. Because specialist, the word specialist has been more commonly used for physicians who practice subspecialties, meaning outside of primary care. The fact is, all physicians are specialists, and for them to have a more concentrated area of training, such as a heart doctor or cardiologist, for instance, they have to undergo a fellowship, and therefore they become subspecialists. But cardiologists, before they train to become or undergo fellowship, are first undergo residency training for internal medicine specialty. So in effect, all physicians already are specialists, even if their practice is general medicine. I will come back to that in the slides later on in this video. But let's go back to the two types. So generalists are also referred to as our primary care physicians. The specialties are family medicine, internal medicine, general pediatrics. They focus more on preventive services, immunizations, health examinations. They also concentrate on longitudinal care, and a lot of chronic diseases can now be taken care of in the primary care setting, such as diabetes, hypertension, heart disease. They will only send you to a subspecialist like a cardiologist, for instance, for additional testing, which is required for your care, an annual check for your heart, for instance. Even HIV, which is now a chronic condition, can be managed in a primary care setting. In addition, primary care physicians, providers, are also considered the first contact of care. So before you go to a subspecialist for a more specific and concentrated type of treatment, you usually go to a primary care physician and then you get a referral from them. Most training for generalists or primary care physicians are in the ambulatory care settings. There is going to be one generalist that is an exception, though, and we will talk about that towards the end of this session. Not in this video, but in this session. Let's briefly discuss the different specialties of physicians that practice general medicine. So we have pediatricians. They have to go through a general pediatric residency. According to the AAP, American Academy of Pediatrics, they could treat 0 to 20, up to 21-year-olds. Family physician are actually trained to have longitudinal care. They could be your pediatrician and then become your doctor as an adult, also become your geriatrician. So from 0 years to geriatrics. Internists, on the other hand, are those that have specialized in internal medicine and they have gone through that residency. They are specifically for adult patients, 18 plus. Although because pediatrics now have can now see up to 21-year-olds, a lot of them would see patients after they turn 22. So this is important with practices like community health centers that have pediatricians and internists. So they will have to turn over their patients when they become adults, and it depends on what their practice really is, whether it's 21 or at 18. Usually also family physicians in this case would concentrate on adult medicine if you have pediatricians in your practice. Now geriatricians are also generalists, but they concentrate on senior citizens, 65 and above. Geriatrics, although it's a general scope in terms of medical practice, is a subspecialty in itself because they have to undergo a fellowship after internal medicine residency. So it's also considered a subspecialty because of the fellowship training that they receive. So going back to that thing I mentioned about referring to subspecialists. So they're often referred to as specialists, but I just want you guys to know that all physicians in the United States are already specialists. Because if you recall, these physicians who are generalists already have to have their own specialty, which is pediatrics, family medicine, and internal medicine. So even if they are generalists or general practitioners, they are, as a matter of fact, specialists in their own right because this is the residency they took. Now, let's go back to subspecialists. So subspecialists are those physicians that concentrate on specific diseases, organ systems, disease processes, and they often receive patients from primary care physicians through a referral. And they train in hospitals through fellowship training. They are required to have an additional certification on top of their specialty. For instance, a cardiologist will first have to do a residency of internal medicine, then do a fellowship training in cardiology, and therefore they get certified also in cardiology. And that is what you call the credentialing examination, which is the board certification. So let's review. True or false? In the US, generalist physicians are technically specialists. And the answer is true. Why? Because we said that even primary care physicians who are technically practitioners of general medicine should have undergone residency training in a certain specialty. And what are the specialties? It could either be pediatrics, general pediatrics, family medicine, or internal medicine, or even geriatrics, which in itself is a subspecialty from internal medicine. Okay, the next review question is true or false? In the US, subspecialist physicians are also often referred to as specialists. And the answer, of course, is true, because more often than not, when we talk about specialists, what we really mean are subspecialists. And the difference of these physicians from generalists is that they have undergone fellowship training, which is an additional training on top of the general residency program that they first underwent. And by the way, that's a big typo right there. I'm just noticing that right now. The word is how. In terms of licenses to be able to practice medicine, the type of exam one has to take depends on which type of medical training, which academic medical training they've undergone. So if you have graduated from a medical school, this is the licensing exam you have to take, the USMLE, United States Medical Licensing Exam. If you graduated or trained in an osteopathic program, this is the licensing exam you need to take, Comprehensive Osteopathic Medical Licensing Examination, COMLEX. Both licensure have 3 steps, 3 separate exams, and they are graduated. You have to take step 1 first, step 2, and step 3. In another video, when I discussed the timeline for physician training, I explained the difference between the 3 steps. Before you can take the licensure exam, you should have graduated from an accredited medical school or an accredited school of osteopathic medicine. Going back to the licensure exam I was talking about, USMLE is administered by the National Board of Medical Examiners, and COMLEX is administered by the National Board of Osteopathic Medicine. So before you get accepted into a residency program, you would have passed steps 1 and 2 first of the licensure exam. But to become a full-fledged practicing licensed physician, you should have been accepted and completed a supervised internship in a residency program. So acceptance is facilitated by the NRMP, the National Resident Matching Program. The NRMP is a nonprofit US-based organization that was established in the 1950s. And their sole purpose is to coordinate the placement of medical school graduates in residency training programs. Now, you need to be matched to a residency program, and it's this nonprofit organization that facilitates that. They have a website, and that's where you apply for residency, and they're the ones that facilitate your matching. Now, the residency programs from teaching hospitals need to be accredited by the ACGME, the Accreditation Council for Graduate Medical Education, and is also a nonprofit organization that is based in the US, and they're the one that evaluates and accredits and makes sure they meet certain standards. I'm talking about residency programs. So they're the ones responsible to make sure that the internship and residency programs, even fellowship in the United States, meet certain standards. In terms of work settings and practice patterns, we see physicians everywhere. Well, pretty much everywhere in any healthcare setting. So they could be in a hospital, they could be in an outpatient facility, they could be in ambulatory care, they could be in an inpatient setting. So you become first residents and become in-house staff physicians for your residency, then you become an attending physician in the hospital. Others also work in public health, such as the CDC, the World Health Organization, departments of health, city level, county level, state level. So we have commissioners of health, for instance. In New York, our city doctor, the commissioner of health for the city of New York, is Dr. Osiris Barbeau. So she is an MD. We also see doctors that work in community health centers, particularly general practitioners.